many, many drugs. Think about when we talked about the second generation antipsychotics, when we talked about the SSRIs and the SNRIs, we talked about how they hit a multitude of neurotransmitters, right? And a lot of them would have histamine. They would interact with histamine receptors. Well, then that comes back when people start to use them or they're treating a disease that has a lot of itching with it. Then they might use some of the drugs in that category that they're already using, like mirtazapine. It is a SNRI, an atypical one, because it has a huge antihistamine property. So if you have people who you're dealing with diseases that can be treated with an SRNI, have itching, that's a drug to use. Okay? You can use opioid, antagonist and agonist, because they hit histamine receptors. So I'll mention those as we go through. I'm not going to spend a lot of time, I just want to raise your awareness. But you can kind of think back through, and as we go forward, if it has an antihistamine effect, then it may somewhere show up that people will use that also for itching, especially when it's a very severe itching. Also going to end up the day with talking about calluses, cords, and warts. So they're fun. Mostly I'm going to talk a lot about over-the-counter because those are easy. Most of those, the cords and calluses, warts, can be treated with over-the-counter products. You also need to be aware of them because patients can get their hands on them, and sometimes they can do a lot of damage to themselves before they show up with you because they're very caustic. And for people with diabetes, they can cause a lot of problems. People who have neurologic disease can have a lot of problems from those. Patients can do their own cryotherapy now. You don't have to go to the dermatologist just to get your warts burned off. You can do it with mild products over the counter. Of course, nothing beats liquid nitrogen, but in the end, need to know kind of about both. I'm not going to spend much time on liquid nitrogen at all, but that's kind of the scope of what we're going to talk about today. So we're going to start with the vehicles. So what is a vehicle? When I say that word to you, what does that mean? Transportation. So that means what? Okay, takes one thing from one place to another. Anything else? Delivery. Okay. How many people can you get in your car? Okay, so vehicles can hold usually more than one thing, right? Okay, so we use that. That is analogous to what we're going to be doing, saying about vehicles and drugs. Anything else? They can hold spots, can't you? Doesn't your vehicle hold a spot out there in the parking lot? Okay. So we use the same term in pharmaceuticals. Is a vehicle is something that holds it all together. It's kind of like your base. And it's what you put everything into, holds it together and puts it in a place and keeps it there until hopefully we can get the drug from outside the skin, through the skin barrier and into the either local or systemic circulation. Okay? So think about that because you're having to get drugs through a barrier. Okay? It's not unlike what we do when we take a drug orally. We have to get it through the intestinal barrier. What other barriers show up before we can get a drug to systemic circulation? Liver, so first pass effect. Some would be enzymes that can intercept. We have enzymes everywhere. We have enzymes even in the lungs that can destroy stuff before it ever gets much systemic effect. Okay. So let's start talking about vehicles. Some of these are probably you know most of these, you've used them. You may not have thought much about them. I'm going to show you. Tell me about what you think about when you think about an ointment. Pardon? Greasy. Mm-hmm. Very good. What do patients think about them? What would you think about if you had to take a drug that it wasn't an ointment?
Stays on longer.
Stays on longer. Good. Do you like to put it in your hair? No. So we don't tend to put ointments, drugs for the hairy areas or the scalp. You see that? Okay. So ointments are pretty much oils. They are predominantly oils and they have some water in them. So they are an emulsion that is predominantly oil. That's why they are so sticky and they hold things very well. So if you've got a drug that you want to stay in a place, use an ointment. If you've got psoriasis and you've got a big area and you're trying to cover it, you use an ointment because it will stay. So look at some of the things we've got down there. They're excellent lubricants. Petrolatum would be in that category. Petroleum jelly. They'll retain heat if that's what you're after. Sometimes that's not what you're after and it makes things worse, so it will keep things in. It is the most potent in keeping a drug in a place, so keep that in mind. So in areas that are very thin skin, we usually don't want to put an ointment there because it will hold everything there. So we don't want to put an ointment in intertriginous, under the breast, in between folds of skin, because it'll trap moisture and eventually it will macerate that area. So it's very powerful in that moisture retentive ability. Semi-occlusive in nature, we use that to our advantage. Understand you're going to do wound care later this week. They'll talk about occlusive dressings and when you use them. I'll show you some example, or at least one example. So if you've got something that's thick, dry, hyperkeratotic, like we'll see in psoriasis, an ointment is your vehicle. But patient acceptance, most people don't like to deal with them very much because they are because they're so greasy. A lot of our vehicles we like to use are creams. Okay, creams are very moisturizing, so we like them. So Cetaphil makes a moisturizing cream, they make a moisturizing soap, they make a moisturizing lotion. So creams are, and we use that word in our everyday language, creamy. So the creams are predominantly water. They do have an oil in them. You can see the difference there in between the ointment and the cream. So they spread better. They will cover an area, a much larger area than an ointment will. So they're semi-solid, you can wash them off with water. You cannot wash off with water an ointment, it just won't go. So that's good. If you're wanting to repel water and you're wanting to keep something moist, ointment's the way to go. They're less potent, so they won't hold anything there as long as what you would get with an ointment. So they'll dry faster, they'll evaporate faster because they've got more water in them. So where it talks about acute exudative inflammation will respond well to a cream, that's because it will let it dry more quickly. Useful in intertriginous, so if you have to use it between skin, it will dry faster, it will not tend to hold the moisture and cause you trouble based on that. Does not have occlusive properties. Lotions. Lotions are like a cream, they're just, they have even more water in them. They usually vanish more quickly, they're very easy to spread. There's a lotion, it's a little bit harder to tell. These are your hairy areas, large areas that you have to cover because the spreadability is so good. They will also evaporate quickly, you may have to apply them more often. They easily penetrate, they don't leave a residue, so patients like them. So sometimes they are an option. Let's see, sometimes they have to be shaken, it depends on how it's been made. So the more you got liquid in a lotion, the more likely you would have to shake it up or agitate it before, especially if it sits for a while. You know, you can see some of your lotions will separate if you let them sit for weeks to months, depending on how well they're made. Gels. So gels are like a lotion. This is a gel. Usually a gel it's a semi-solid, it has high volume of water, but it always uses alcohol as a base. So you can tell that when you come up here, this thing is 63% alcohol. So why is that? What's the alcohol good for? Evaporation, it dries very quickly. So if you want something that will apply a drug and then leave, like in the hair, or in hairy areas, then gels are the way to go. Or we use them like they've adapted it well, the manufacturers have, to something like a hand sanitizer, because within a few minutes, they're gone. They are also look more solid, but when you put it on your hand, what happens pretty fast? They melt pretty fast, so they will go to a liquid quickly when they've got some heat or some agitation or shear forces on them. So that is, that's a gel. If you put this on skin that is inflamed, what will happen? It burns. Okay, so you wouldn't want to use it on in lesions like that. Foams, mousses, shampoos, those are all very similar in that category. A mousse is just you have dispersed little gas bubbles within and the drug in a liquid that will then will cause a foam, but it has to have a device to do that, right? So we have a lot of some corticosteroids that come as foams. They're almost always used on the scalp. They are very expensive because they require a device to actually activate them into the final product. They're good because they evaporate quickly, they deliver the drug, usually in hairy areas is where you're mostly going to use a mousse or a foam. Let's see. So solutions have a high degree of liquid in them. So think about solutions. A lot of syrups are a water and sugar solution. Look at my notes. They can have alcohol. Think about a lot of the drugs you use that are very liquidy are usually solutions. So you've got a drug that is dissolved in a product, as opposed to a suspension where you've actually suspended it, or an emulsion where the two different products have been mixed together in a unified product. So liquids. We don't use them that much with derm, but they are something we can use. A spray would be something like that. A spray would be a solution that we can use a device to apply to a large area. Usually has some alcohol in it, so it will evaporate. Okay, we talked about foams. Talked about gels. I think I've covered most of them. Any questions about those different? So when you get on derm, you're going to learn which vehicles will go with what type of dermatoses you're dealing with. Most of the products, most of the topical steroids have multiple vehicles. So you'll find them as creams and ointments and foams and solutions and tapes. We even have one that is in a tape that you can tape down over a lesion. Does this have so we talked about all of those. I thought I put this one in here, but maybe I didn't. On page 3, there is a very nice occlusive dressing. You can use something like Tegaderm over a 4x4 or over a nonstick pad. You can use saran wrap. Anything that would keep moisture in and air out is usually occlusive dressing. That would be when you really wanted to keep a drug in place. You wouldn't want to use it in areas that have very thin dermis or in intertriginous areas. It would be very potent in terms of the effect. So occlusive dressings will increase the potency of a drug many-fold because it helps to drive the drug into and through the skin. Never would put it on the face. The face is also fairly thin and can really, in a very short period of time, develop side effects from the topical steroid. Often used overnight. That's a good one to remember. Okay, look at the next page, page 4. I want you to know the preferred areas. So look at the different vehicles. This is a very nice compilation out of UpToDate. And you see your vehicles on the left-hand side, and then you have your smooth, non-hairy, thick, hyper keratotic lesions. That would be like our psoriasis. Hairy areas, palms and soles, which are going to be very thick, infected areas, and then your more intertriginous areas. So in your objectives, I've noted that I want you to know at least the preferred. So ointments are preferred for non-hairy areas, hyperkeratotic lesions. For your hairy areas, it's your solutions and foams, and etc. So you don't have to know all of them, but the ones where it's the one you're most likely going to want to use. Questions about those?
Yes, I've been exhausted.
All right. So some clinical use indications, lots of indications, lots of dermatoses. So we're going to talk about those in particular. You know, inflammatory would be an important one, and steroids would be very potent in those. Pruritic lesions as well. Contraindications are important because if you use a steroid alone in these indications, it will make the underlying problem worse. Okay. So acne may clear up as you have the steroid on it, but as soon as you remove the steroid, I'll show you a picture of it, it will rebound in spades. So really important. That's why we like to keep very low potency steroids on the face if we have to use them at all. Scabies, warts really don't, they're not an inflammatory process, they're viral, so they really don't respond to a steroid. Fungal infections, you will make a fungal infection worse. It's one of the ways if you misdiagnose something and you put a steroid on a fungal infection by itself, it will just get worse, it will not get better. But we can use an antifungal and a steroid prep together. They come that way commercially initially because fungal infections tend to be very itchy. So we can decrease the pruritus and the person's scratching all the time in the first day or two and let then the antifungal do its work because it will take more time for them to respond symptom-wise. Viral infections, virus will not respond to a steroid, so you can actually make the other processes or the other symptoms worse by applying them. So in terms of components of successful use of topical therapies, the first is the correct diagnosis. Duh. Okay. So we got to know exactly. We got to be pretty sure that we know what we're dealing with. That's the thing with derm to me, is that I'm amazed at dermatologists, because my dermatologist will walk in, look at your skin and walk out, and you're like, how did you know? Because to me, they look like 10 things could be that. So getting the correct diagnosis is important. The type of lesion being treated, is it weepy? Is it dry? Is it hyperkeratotic? Where is it located? All of those will help you in terms of choosing which drug to use. The vehicle, I've kind of given you an idea now of why the vehicle is important and which ones you would choose. I've given you some examples there if you have the right medicine but the wrong vehicle. The first example is you use a steroid gel on the hands where the person has eczema and fissures. You get increased pain and stinging due to the alcohol base of the gel. So you all alluded to that earlier. A second example is treating a moist lesion with an ointment can cause a folliculitis because of the increased moisture and the occlusive properties of the ointment. Methods used to apply the medication are important as well. So we're wanting to get the drug through the skin. So inclusive dressings will enhance absorption by a factor of 10. That's quite a bit, especially if you're using a very potent steroid. The site of the application will make a difference depending on how many layers that the drug has to go through. Sometimes you have to pare down or use like a pumice stone on the soles just to get the calluses off in order to get the drug to go through. On top of page 6, skin integrity is important because a lot of these dermatoses will have disrupted skin barrier. If it's inflamed, the drug will go through faster. So some of that we can use to our advantage because we can get the person feeling better quickly because the drug is going to go through and get absorbed and exert its effect. If there's been desquamation to the area and the skin barrier is very disrupted. So the takeaway point is the more abnormal the skin is, the more likely and faster the drug is going to go through. And the vehicle can more irritate or help depending on which one you choose. That's the takeaway. Okay. If you use very potent steroids on an inflamed or broken skin, you will get a powerful effect. For a day or two, that's good. If you go weeks with that, then you can get a lot of skin absorption of that steroid, and then you can get the side effects. So what are the long-term side effects of steroids, systemic steroids? Why do we not just give them out? They sure make people feel better. Why aren't they over the counter? Pardon? So immunosuppressants, what else? Osteoporosis, long-term, they help calcium leach out of the bone. What else?
Cushing's.
Cushing's, Cushingoid syndrome, too much, excess, steroid, what else? Blood sugar, so diabetes, hypertension, goes along with Cushingoid, we see that. What else? What about the eyes? Why don't we put steroids in the eyes? That would help. Why don't we do it for pink eye? Glaucoma maybe, but what's the more?
Intracranial or inner pressure or something?
Cataracts. Bruising, skin thinning, muscle wasting, skin thinning. You can see purpura. I'll show you some pictures of that because of this thin skin. Allows the little blood vessels are more vulnerable, then they bleed more easily under the skin. Patients' age, infants and children under 12 have very thin skins. So if you use we don't use high potency unless there's a really good reason to. They have a severe dermatitis or something that requires that potency, but we use low potency on kids because of their thin skin, especially infants. And the body surface area. So you got a very small little body, if I put a little bit on Ron, it's not much. If I did it on the son, the same amount, I've covered a greater percentage of his child's body surface area. Talked about the vehicle use. Areas of the body to which it is applied. So intertriginous zones, think about the folds between your skin. It's very thin. You don't like to be tickled there, do you? You don't like people to touch it. It's more sensitive, and so the drug goes through. Forehead, scalp, those are thinner. The face, forearms are pretty tough. So the regional differences are listed down there. You could guess those. Aren't for most of you your thickest skin on the soles or of your feet? Yep. Palm of the hands, pretty tough compared to, let's say, the ends of your fingers even. Scalp, forehead, mandible, genitalia. So when we put steroids on the genitals, it's a mucous membrane. It can absorb it very quickly. So you'll see that when we talk about diaper rash, because we frequently will use an antifungal and a steroid on a diaper rash. So we've got a very thin area that we can get lots of effect. Questions about those? Okay. So where you put it, how you put it are really important, and how much you put it, and how long you put it. And all of those will lead to cure, but also side effect. So potency of topical steroids. On the next page is a abbreviated list of agents in all of those areas. There's a number of steroids that I didn't even list, but these are some of the more common ones, and most of them are generic, so they would probably more likely be used. Potency is really weird. How do you think they would determine the potency of a steroid? I would think it's on how much you can dampen the HPA, the axis. That's what I would think. It's actually based on local vasoconstrictive activity. I have no idea why, but that's the way that it is set up. So class 1 or group 1 are the most potent. They're super potent. They have lots of superpowers. And group 7 is the least potent. It is easy to remember that because hydrocortisone is over the counter and it is the only one in that category. Okay? So we don't put clobetasol over the counter. It's the super potent one. It's 1,000 times more potent than hydrocortisone. Okay? When you look at that, look over at that chart on page 7. You'll see multiple drugs listed in multiple different potencies. The difference there is strength. So if you pick out triamcinolone or fluocinolone, you'll see that it appears in multiple categories. But if you look at triamcinolone where it appears in the highest, it is also the highest strength. So strength can change the potency. If you also look at, I think, triamcinolone, where it appears as an ointment, it is more potent than when it appears as a liquid solution, or a lotion? Yeah, if you look at, it ends up as low potency, it's a 0.025% lotion, versus, where is it? High potency as a 0.5% ointment. Okay, so that's different. So it isn't based just on the drug, it's vehicle, and it is the strength. In your objectives, I've listed 5 that I want you to be able to identify. So hydrocortisone's a given. It's an over-the-counter, you know it's number 7. Clobetasol, most super high potent one we have. Okay, that's number 7. And I've given you 3 in the middle. I think 2 are triamcinolone. 1 will be based on the vehicle will be different and the strength is different. And fluocinolone is the other one. Okay. Questions about those? Mostly here I'm going for concept. The other thing I'm going for is when I ask you a question, I'll tie it to a drug. That's why you need to know which one it belongs to. And these are common. Triamcinolone is dirt cheap. Hydrocortisone, dirt cheap. Clobetasol is now generic, and it's fairly inexpensive. So most of the generics, as long as they're an ointment or a cream, are pretty cheap. As you go more and more different in terms of vehicle, the more expensive the product will get. Okay. Top of page 8. So here's a time where we want the lowest amount of steroid that will control the problem. Now if you think about asthma, where else do we use this? If we're talking about steroid bursts for other diseases, we usually start high and we taper down, right? Here we really try to, because usually for dermatoses, you are going to use these products for several weeks. So here we want to use the lowest potency that will do the job. For some of your severe dermatoses like psoriasis, we're going to use very high. So there aren't that many where we use a very high. There's some autoimmune type skin diseases where we will use a very high potency. But most of those, it's not going to be a very common one. Where things are thick, like palms, the soles, very thick skin, we'll use the higher potency. We usually don't start using any on the face until we get to the low potency. Even the medium potency can be too high. So you'll see that listed. Most of the time you're going to use the low to medium for most of your general things that you're going to see walking your office. Usually steroids are more effective if they are applied to moist skin. So teaching patients, like they take a shower or a bath in the morning, apply it after that. You can apply it to dry skin, it will be effective, but it's much more effective if you'll do it to moist skin. Principles for use, we've talked about product strength, frequency. There is no need to use a topical steroid more than twice a day. You can use it more frequently, but it usually doesn't increase the efficacy that much more. It increases cost a lot more, and it can increase the risk of the person developing a side effect. Administration, rubbing it in thoroughly, using very thin application. This is hard to get across to patients. I'm going to show you something tomorrow when we talk about psoriasis, because it'll say apply a ½ inch. What do I do? I get a ruler out, lay it down? Well, something like that. I'll give you some guides and visual guides to doing that tomorrow, but a really thin. These, especially the higher the potency, and you've got an ointment which will actually spread well, even in a very thin layer will be very potent. So thin layers. So it isn't like you slather it on and like put butter on your bread. It's very, very, very thin. Areas of the body that are more susceptible to having a side effect would be occluded areas. So it's got an occlusive dressing on it. If it's occluded in terms of it's in the genital area, if it's in intertriginous area, under the arms, something is laying against it. That would be a more occluded area. The thin places, skin places of the body we've talked about. Let me just comment on that last statement about if you have to use the face or flexures, using hydrocortisone, so a low potency or a non-fluorinated topical steroid like triamcinolone. So, long time ago, all we had was hydrocortisone, triamcinolone. I'm telling you all, you were born too late, because if you were born 30 years ago, you wouldn't have so many drugs to run. So, what they started doing was looking for more potent, because we had dermatoses that we really couldn't control very well with those lower potency products. So what they started to do, the scientists, is they started manipulating the steroid molecule to see if they could increase potency. So what they did is they started putting halogens, they would fluorinate the steroid, they would switch around where the different sides were attached, different like C9 or C6, and they became more potent. So like your, I don't know that I'm gonna look back on that page with all the listing. No, page 7. Under high potency, Halog is a halogenated steroid, very potent. Clobetasol is a fluorinated, I believe, very high potency. So your halogenated, your fluorinated, or the higher potency. You can even see it in their names, like fluocinolone is a fluorinated. So your lower ones, like triamcinolone, I'm trying to think if there's another one. Those are your two, mostly your non-halogenated and non-fluorinated low potency. That's what that's referring to. Your vulnerable populations, thin skin, babies, so infants, so they'll have eczema, they're coming out into the world, and now they're exposed to all the environment, and they'll start developing little skin problems. So babies are more common, children, elderly, thin skin, thin skin, and then patients with liver disease. The higher the potency and the longer you use it, the more likely systemic side effects. So keep that in mind. And they can get significant suppression of the HPA axis. So hypothalamus, pituitary, adrenal axis. Treatment duration on page 9. So super high potency, so that would be like clobetasol. Would like to see it not used more than 3 weeks. Lower potency, the more medium to high potency, would be in the 6 to 8 week range. So it's not only systemics that we're worried about, it's skin side effects as well, which I'm going to show you in just a bit. 2 concepts I want you to keep in mind. Some dermatoses are going to be, they're always going to have them. They're never going to get rid of them. Those that are more autoimmune, like psoriasis, like some of the lichen planus, lichen sclerosis, those are autoimmune, and they aren't going to go away. So what we want to do is calm down the response and get them to where they're asymptomatic, and then we're going to put them on intermittent therapy. So what we try to do is move them from daily, once we've got it, the condition cooled down, then we will try to go to twice a week. Small doses twice a week, just to keep the immune system from reacting, or causing, not reacting, but causing symptoms. So know the concept of intermittent therapy. It's usually with chronic therapy, it's usually twice a week that we try to do. The other is just like with oral, when we give big doses for long periods of time, we taper. We do the same thing with topical. The longer you've had somebody on a topical, as you withdraw it, as you decrease, if you just stop it, they'll rebound. So that all the symptoms will come back in force. So tapering slowly, and it takes a long time, just like it can when we're dealing with people who have been on steroids for long periods of time, like weeks to months. We taper at a much slower rate. We talked about that with RA, that when we've got them on, remember we bridged them with a steroid for 6 months, and when we, waiting for those DMARDs to take place, and if we take them off too quickly, their symptoms will come back, and we take them off slowly, same thing here. So keep in mind the concept of intermittent and the concept of tapering them off of, or down to maybe a lower potency or a lower dose. Questions about those? Kids, if you have to use a steroid in a kid, then use group 4 to 7. If you have to use a higher dose, then you just have to try to keep moving it down as quickly as possible. I put down there, I'm not going to call these back on you, but, a couple of things. One is with kids, we try to go with once a day steroids, and also to not use more than 2 weeks. I've given you some dose, because there really aren't good dosing guidelines for kids in the literature. So here are some guidelines. For infants, use 1/5 of the adult dose. For kids, 2/5 of the adult dose, and adolescents, 2/3 of the adult dose. There's really limited data in pregnancy and breastfeeding, and very little in breastfeeding. So it's recommended if you can get by without it, don't use it. Advise women don't put the steroids on their breast, on their nipples if they've gotten sore nipples. That may feel really good, but that would be a whopping dose for the infant. If you have to use it in pregnancy, again, you're going to use the lowest potency for the least amount of time. If you have to use a high potency for a long period of time, then monitor the fetal growth, because it will stun it. Remember we talked about in asthma, the one thing you have to worry about with using inhaled steroids is parents' awareness that it will delay growth. We talked about that it doesn't have any effect on their end growth. They'll reach their height they're supposed to, but it takes them longer. Okay? So think about that and apply that to the infant. If you're doing that to the infant, and they'll get all the effects that the mom is getting, then their growth may be retarded behind their gestational week. Y'all look really tired. Is this from the test yesterday? Did you go out and party last night? It's only 10. I should get benefit. You should be awake, coffee should be in place, and you haven't eaten yet. Lunch. Okay. Okay, let's take a break here. We'll come back and talk about the side effects and pick up on page 10 when you return. So if we'll start back about 5 after, that would be great.